Hi everybody, it's Conrad Fisher. The fish loves you. Rate and rhythm disturbances. Sinus bradycardia. We got a 48-year-old guy who comes in and what else he gonna do to get a 48-year-old person in the door for no particular reason? Hi, I just want to come in and tell you I felt asymptomatic today. Chief complaint, I'm fine. How are you? Well, travel vaccinations, diabetes, screening, health form clearances, traveler's diarrhea, no particular reason, Viagra, and you find the person's got a pulse of 40 for no particular reason. Well, the first thing is that you don't do anything about an asymptomatic person, except you gotta get an EKG. You can't just do nothing. So I want to tell you that the most common mistake on the bradycardia question is automatically assuming that all asymptomatic bradycardias are sinus bradycardia. So if you have sinus bradycardia, there's no treatment. But bradycardia has to be confirmed as sinus bradycardia. Because if you don't confirm it as sinus bradycardia, you don't know what's there. So the asymptomatic sinus bradycardia gets no treatment. But how do you know it's asymptomatic sinus bradycardia? You got a mind reading? You know it's not? You know? Well, you don't know until you get an EKG showing you it's sinus. Other than that, it might be complete heart blocking. Maybe they're ready to have syncope while driving down the opposite lane of traffic from you on a highway. Uh-oh. Asymptomatic people have to have an EKG to confirm it's sinus. You can't assume it's sinus just because it's asymptomatic. A person has sinus bradycardia is defined as a heart rate less than 60 with a normal width and evenly spaced nice cute ventricular complexes. It's not pathological. It's not pathological in pretty much anybody. President Obama has a heart rate of 38. It's not pathological. That's why he's calm all the time. What do you need, walk up and put a pacemaker on the president? I don't think so. Mr. President, I need to give you some atropine. That's not true. You don't need to give me atropine. That's not true. You don't need to. So even if it's an asymptomatic person of any kind, sinus bradycardia gets left alone. And that's because this heart rate normal of 60 to 100, who decided that? Well, that's based on World War II military recruits, the ages of 17 to 24, who were men, 2 hours postprandial in the supine position. And we decided that 60 to 100 was normal. Well, who said that? Well, we statistically had to make a definition. We decided that 60 to 100 was normal. It depends who you are. Some people are normal at 50. That's the way it is. The etiology of sinus bradycardia is so multifactorial that you always treat the underlying cause. It could be a big nothing, or it could be somebody who's got increased vagal tone, like an inferior wall MI, pressing against the diaphragm, or carotid sinus pressure, or Valsalva, or a person who's vomiting and having increasing vagal tone, or venosiazines, or digitalis, or just nothing, because it just happens. Sometimes bad arrhythmias happen to good people. Sinus node automaticity can be impaired with beta blockers, calcium blockers, or just conditioning. Is that impaired? Why are we turning being a healthy athlete into a disease? I don't know why. You see, if it was hypothyroidism, it means it's time for you to take some Synthroid. But in a generally healthy person, don't do anything about it. Just leave it alone. That's the key issue. The clinical presentation has an awfully wide range, and it can be asymptomatic to syncope to lightheadedness to hypotension. Now, the same way if it's asymptomatic, it doesn't matter what the etiology is too much. If it's symptomatic, it doesn't matter either. If it's symptomatic, you got to treat it, no matter what the etiology is. Atropine, speed it up. You can't tell till you get an EKG. For sinus bradycardia, if it's asymptomatic, leave it alone. If it's sinus, if it's third degree AV block, you got to put in a pacemaker. If there's symptoms, atropine. Why not use epinephrine? That'll speed up the heart. And that's because epinephrine, since so much of ischemia can be causing a bradycardia. What if there's ischemia of the node? You gave them epinephrine. You just killed them. So you can't use epinephrine. Atropine decreases vagal tone, will speed up the heart rate. If the atropine does not work, pacemaker if there's symptoms despite the atropine. Pacemaker if the symptoms despite the atropine. Let's look at some blocks. AV block is anatomical. It's based on the site of the block. Is determined by the His bundle. His bundle? No, the His bundle. Her bundle? No, the His bundle. Bundle of His. And you can see on an EKG, and there's 3 types of block. First, second, and third degree. First degree is irrelevant, no treatment. Second degree might be irrelevant, wanky back. Might need a pacemaker, Mobitz 2. Or might need a pacemaker now. Third degree, AV block. First degree AV block is a clinical irrelevancy. Don't do anything about it. It's a PR segment that's greater than 200 milliseconds. Remember that 200 milliseconds is the upper limit of a normal PR. The lower limit is 120 milliseconds, 120 to 200 milliseconds. And prolonged PR interval by itself means a big nothing. Don't do anything about it. Don't get scared. Leave it alone. Leave it alone. Don't do anything for first degree AV block. It's irrelevant. First degree AV block can be degenerative changes. Used to be called Lenegre's disease. It's just basically the male pattern hair loss of cardiology. I know you don't like how it looks, but I'll tell you for sure, it doesn't interfere with function. It's just a little male pattern hair loss, little aging of the conduction system, but there's no problem with the contraction if you get my drift. Now, it can also be from digoxin or exaggerated vagal tone, ischemia sometimes, but nevertheless, though, the majority of it is a cardiomyopathy or just getting older. Leave it alone. Don't touch it. Now, Mobitz 1 and Mobitz 2, the second-degree AV blocks, might be pathologic based on the symptoms. If they're symptomatic, then you treat them, atropine, and if they persist in their symptoms, a pacemaker. But if they're asymptomatic, here's the key point. Mobitz 1 is a gradually prolonging PR interval until you stretch, drop, stretch, drop. And Mobitz 2, you just drop a beat. Mobitz 1 or Wenckebach looks scary to people, but it doesn't go anywhere. It doesn't progress. The QRS is normal. Well, in Mobitz 2, the QRS is generally normal as well. The other thing is that most of the time, it's normal in terms of the QRS, and so therefore, I don't want you learning the QRS difference as a means of telling the difference between them. They both can be caused by degenerative disease. However, Mobitz 2 is more often caused by ischemia. That's why Mobitz 2 is worse and Mobitz 2 progresses. Mobitz 1 can be degenerative. Mobitz 1 can just be from drug toxicity that doesn't mean anything. Mobitz 1 can have been from old myocarditis or rheumatic fever, but most of the time it's a nothing. Third degree AV block or complete heart block or AV dissociation are atria and ventricles that are contracting without any relationship to each other. All the atrial beats are blocked and the ventricle is beating entirely on its own. It's like a bad marriage. And the AV dissociation is present. There's no relationship between the atrium and the ventricle in terms of their beating. That's why the P-to-P intervals are regular and the R-to-R intervals are regular, but there's no relationship between the P waves and the QRSs. AV block, third degree AV block, can happen from ischemia, particularly of the AV node from the right coronary artery. It can also happen just from degeneration of the conduction system. Lenegre's disease, if it gets really bad, can actually block down the AV node. It can happen from infections or inflammatory processes that damage the conduction system. So an abscess or a tumor or infiltrative diseases, rheumatic fever. That's a short way of saying, why don't we just say the word everything? Yeah, that's good. Drugs like digoxin can block down the AV node and cause an abnormality of the conduction system if they infiltrate in and block down that node. Third degree AV block, when it causes a sudden loss of consciousness, can also be called a Stokes-Adam attack. Now, Stokes-Adam attack is a generalized name for all forms of sudden cardiac pump failure, and so sometimes people use it interchangeably with the term for asystole or VTAC. But the Stokes-Adams attack particularly means third degree AV block. And that means that there will be bradycardia associated with that third degree AV block, resulting in a loss of consciousness. The management of this is to have atropine and a pacemaker. Our next section is looking at sinus tachycardia. Now, sinus tachycardia is almost always simply the management of what is the underlying cause. A normal heart rate is defined as 60 to 100, so this is a heart rate above 100. Everything else is normal, it's just going fast. The key issue is it's a physiologic response to fever, hypotension, or volume depletion, or anxiety or pain, or preparing for step 2. Or it can be a physiologic response to hyperthyroidism, anemia, and some drugs. The moral story is never answer a medication like beta blockers for sinus tachycardia. The answer is always either do nothing or fix the underlying cause. Supraventricular tachycardia is not from ischemia. That's the most common mistake. Supraventricular tachycardia is an anatomic defect in the cardiac conduction system. It's an abnormal wire going around the AV node. It's an ectopic tachyarrhythmia, sudden onset, sudden loss. You can never have chronic. It's never to be considered chronic SVT. 80% are caused by re-entry. The heart rate is on average 160. You can never leave somebody chronically at 160. That's the colossal difference between AFib. Sure, leave it alone. Don't convert them. Don't change it. Sinus tach. Don't do anything at all except correct the underlying cause. SVT, very different. Always needs treatment just for the arrhythmia. Sinus tach never gets treated just for the arrhythmia. SVT, supraventricular tachycardia, always is treated just for the arrhythmia because there's no underlying cause like another disease. It's an anatomic defect in the conduction system. And that anatomic defect is not from ischemia. The best initial therapy is carotid sinus massage. Pressing my carotids, dunking my head in a bucket of ice. Valsalva. Dive, dive, dive. And if adenosine does not work, then we go to other medications, such as beta blockers, calcium channel blockers, or digoxin. Which beta blocker does not really matter. Now, propranolol is generally not used by cardiologists. Would it be effective? Yes, it would, but you don't need it, man. We need that beta 2 stuff for it. Get that. Why don't we try some nice, good old-fashioned, traditional metoprolol? Ooh, it's so tasty, so nice. I have something for you today. Today's daily special for cardiology is very nice. It's metoprolol, yes. Unstable patients are very rare. Shock it, shock it. And the reason unstable is very rare is because you don't live off your atrium. SVT, always must be treated. Vagal maneuvers first, failing the vagal maneuvers, adenosine. Guess what the single most frequently asked question on step 2 is for EKGs? A person has SVT, they failed carotid sinus massage, what do you do? Adenosine. That's it. That's the single most frequently asked step 2 EKG question. Multifocal atrial tachycardia is an atrial arrhythmia with 3 different P-wave morphologies, and it's seen mostly in people with chronic lung disease, multifocal atrial tachycardia. If it's slow, the same disorder is called wandering atrial pacemaker. There's 3 different P-waves. It's from COPD, fix the underlying cause, and avoid beta blockers. Well, if you're not going to give beta blockers, what are you going to do? You're going to give calcium blockers. That's it. It's from COPD. Avoid the beta blockers because of COPD. And use diltiazem and verapamil. Now, not all calcium blockers work on atrial arrhythmias. Diltiazem and verapamil do. But the dihydropyridines don't. Nifedipine, amlodipine, nitridipine, nicardipine, felodipine, amlodipine, the pines don't work. For arrhythmias, it's diltiazem and verapamil. Atrial flutter is an unstable rhythm. You don't stay there. You either go back in the sinus or you go into fibrillation. But it is a regular rhythm. Flutter has a sawtooth pattern that is very, very distinct. Atrial flutter is like the same causes that cause atrial fibrillation. COPD, PE, thyrotoxicosis, mitral valve disease, alcohol. Anything that dilates the left atrium can cause atrial flutter. The same thing, anything that dilates the left atrium can cause atrial fibrillation. Very rarely is atrial flutter associated with hemodynamic instability. That's very rare. It's very unusual. However, if it happens, and you have chest pain, shortness of breath, hypotension, confusion, and you're unstable, you shock them. Synchronized cardioversion or unsynchronized? Synchronized cardioversion, because there's something to synchronize too. Now, 98 to 99% will be hemodynamically stable. Digoxin, calcium blockers, beta blockers. And the beta blockers can be anything, but metoprolol is probably most useful. The calcium blockers are only verapamil and diltiazem for atrial arrhythmias. Verapamil and diltiazem for atrial arrhythmias. Atrial fibrillation is the most common arrhythmia that there is. Atrial fibrillation is from anything that dilates the left atrium Atrial fibrillation is from anything that causes a cardiomyopathy, any valvular disease that dilates the left atrium, which is almost all of them. And the P waves are replaced by fibrillatory waves that are completely random. And not only are they random, the R to R intervals are random too. So you have irregular P waves. Well, they're not P waves if they're irregular. They're called fibrillatory waves. And irregular R to Rs. And there's uncoordinated atrial activity. And eventually, atrial function will decline. Atrial fibrillation is mostly secondary to underlying heart disease that causes left atrial hypertrophy and enlargement. The most important thing about atrial fibrillation is that the stasis that occurs puts you at risk of thrombus. And that thrombus becomes embolus. And that embolus becomes stroke. And all the management of AFib is now simply rate control and anticoagulate. Rate and anticoagulate. The first thing in atrial fibrillation is, are they stable or unstable? 99% are hemodynamically stable. In the rare person who's unstable, you would shock it. What does unstable mean? Chest pain, shortness of breath, hypotension, confusion. Chest pain, shortness of breath, hypotension, confusion. And if that happens, you'll shock them. Synchronized or unsynchronized? Synchronized. Matter of fact, everything is synchronized except ventricular fibrillation and pulseless VTAC. So what you're going to do is you're going to look for a very irregular rhythm. And the first thing is to try and do rate control. Now, why not vagal maneuvers like you did for SVT? Because it won't convert it. It might slow it down for a minute, but it won't convert atrial fibrillation. The CHAD score is one of the most important things that you can learn for your examination. The CHAD score determines who needs to be anticoagulated. Since atrial arrhythmias are rarely hemodynamically unstable, and since routine cardioversion is not done, the key issue is, after you control the rate with a beta blocker, calcium blocker, or digoxin, who should be anticoagulated? CHAD score is a prediction rule for estimating a risk of stroke in a person with atrial fibrillation. And you basically determine if you have a CHAD score of 0 or 1, you get an aspirin. But a higher CHAD score means that you're at risk of a stroke. This is a must-memorize subject for you. C means congestive failure by echo or by symptoms, either one. Hypertension, age over 75, diabetes, and stroke, S for stroke, automatically means 2 points. Stroke or TIA. And the bottom line is a CHADS of 0 is aspirin. CHADS of 1 is also generally an aspirin as well. And CHADS of 2 or more means warfarin or dabigatran, rivaroxaban. This is a must-memorize fact. The EKG is done to assess the rhythm. It also assesses the presence of certain LVH or pre-excitation. Is there Wolff-Parkinson-White? Has there been a previous MI? Yes, you need to do a chest x-ray to see about the lungs. Is there COPD that caused part of this problem or other lung disease that's leading to the AFib? But that's not as important as CHAD scoring. The echocardiogram is important because it's how you assess whether there's congestive failure. And since it may change the treatment to give somebody warfarin, dabigatran, or rivaroxaban, it is fair to say that every single person with atrial fibrillation must have an echocardiogram. That's the fact. Is there valvular disease that needs to be fixed? Is there mitral stenosis? Maybe you can fix it. Is there a thrombus that automatically means you need to be anticoagulated? And forget about CHADS. If you got a thrombus, you need the anticoagulation. Thyroid function tests are done because if you have hyperthyroidism, you can fix the hyperthyroidism and then the atrial fibrillation will simply go away. Let's look at atrial fibrillation management as basically 3 things. Are they hemodynamically stable? If they're unstable, chest pain, shortness of breath, hypotension, or confusion, you do synchronized cardioversion. Okay, they're stable. Ventricular rate control, beta blocker, calcium blocker, digoxin. Okay, you've controlled the rate. Now, let's prevent those embolic complications. CHADS of 0 or 1, aspirin. 2 or more, warfarin, dabigatran, rivaroxaban. Now, there's 2 ways to look at the AFib management in terms of rate control or rhythm control. There's no benefit to trying to shock people into sinus. People don't like that. They have a hard time with it. They're like, what do you mean? You're just going to leave them in AFib? And the answer is, yeah, you're just going to leave them in AFib. But isn't that bad? Yes, it is bad, but it's not any worse than trying to shock them or medicate them into a rhythm where they're not going to stay. See, that's one of the things people don't get. You can try and shock them into sinus, but they don't stay in sinus. As a matter of fact, 93% of people are going to convert right back. The standard of care is slow the rate and anticoagulate if it's greater than 1. Use rate control when a patient's symptomatic or has minimal symptoms during the arrhythmia. And the only person who might get rhythm control is when there's marked symptoms, meaning I'm short of breath. The rhythm control is a mechanical cardioversion. It's electrical shock that sometimes you do to fix it, to get it back into sinus. It's synchronized to make sure that you're not giving the electricity during the refractory period. And occasionally you do it electively in patients who are persisting in AFib despite medical therapy. You definitely do it if they're unstable. But the question is, in the elective cardioversion, for the stable person, who does this? Well, 1, young people. Number 2, when there's no major underlying cardiac disease. For instance, if the echocardiogram shows a big dilated left atrium, we're not going to do it because it's going to convert right back. But what if you have a 28-year-old Venezuelan medical student who has an otherwise normal heart, no hypertension, no diabetes? Well, he might stay in sinus if you shock him into it. And you have to anticoagulate before and after. The rhythm control, the pharmacology, geez, these are a great idea if they would just work. They're less effective than electrical cardioversion. They carry the same risk of thromboembolism. And drugs like amiodarone, dofetilide, flecainide, enconide, ibutylide, propafenone, quinidine, all of them work in some people, but the problem is they don't work in everybody, and again, they convert back into AFib. And the problem with dofetilide and ibutylide is a little problem called torsade de pointe. Oops! Oh, listen, Mr. 28-year-old medical student from Venezuela, sorry. That arrhythmia that wasn't going to hurt you, well, it looks like I caused torsade de pointe with your drug that could convert you. Sorry, you're dead. Oops! Using catheter ablation is done in otherwise healthy young people, and basically AFib can be controlled with a catheter ablation in some people by going in from the pulmonary veins to ablate the site of the location. It will have to specifically say the person is young, not 80-year-old, 70-year-old, leave them alone. The heart is otherwise anatomically normal, and there's a very low risk of recurrence, and then you could try it. But the most important thing on atrial fibrillation management is rate control and anticoagulate. CHADS, and knowing that it's congestive failure, hypertension, age 75, diabetes, stroke, or TIA, either one of them gives 2 points and automatically means warfarin, dabigatran, or rivaroxaban. That's the most important thing. And remember, dabigatran and rivaroxaban don't need INR monitoring. They're oral drugs. They don't need INR monitoring, and that's the big thing. They're easier to manage, and they have as good or better efficacy. My goodness, doesn't step 2 just love Wolf Parkinson White? You gotta love Wolf Parkinson White. Yes, you do. It's all or some portion of the ventricle activated by atrial impulses earlier than it's supposed to. It's a pre-excitation. There's an accessory pathway. Kent bundles, extra bundles, Bachman's bundles. And you pre-excitate and you get SVT or VTAC, SVT or VTAC. Wolf Parkinson White has got about 7 basic questions. The first one of which is that you understand pre-excitation means a short PR. How short is short? Short means less than 120 milliseconds. That's what short means. Short means less than 120 milliseconds, which is the normal lower limit of a PR. The QRS looks wide, but it's wide only at the bottom, and recognizing that delta wave, isn't it beautiful? Look at that delta wave. That's a beautiful delta wave right there. And you better go with that delta wave before you walk into that test. You're going to get your ass kicked. If Wolf Parkinson White is hemodynamically stable, and you have, now this is the key issue, hemodynamically stable, but you have ventricular tachycardia or supraventricular tachycardia now, not just a delta wave. What are you giving the procainamide for? You're giving it for the arrhythmia, not just the delta wave. You use procainamide or amiodarone. You could say avoid digoxin the same way you could say, why don't you avoid assassinating people or running people over with your pickup truck? It's better to say, don't give digoxin or calcium blockers. Is that a better way of saying it? No digoxin or calcium blockers. Unless somebody says, doctor, my family needs the insurance money. Can you kill me with DAGE or calcium blocker? Don't do that. Because they inhibit the conduction of the normal pathway, and they drive it down the abnormal pathway. They inhibit the normal conduction pathway, and they drive it down the abnormal pathway, and you force them into VTAC, or supraventricular tachycardia, by forcing it down the abnormal conduction pathway. Unstable patients get synchronized cardioversion. What do we mean by unstable? Chest pain, shortness of breath, hypotension, confusion, means you're not getting enough perfusion. And then you shock them. And the long-term therapy is ablation. Cook it out, fry it out, burn it out. Wolf Parkinson White is a straight-on-ahead thing where you get these 7 questions. Can you recognize a short PR? Less than 120 milliseconds. Can you recognize the delta wave? Procainamide or amiodarone if you have symptoms right now. Ablation is the long-term therapy. Don't use calcium blockers or digoxin because it makes it worse. And it's the only thing that gives SVT alternating with ventricular tachycardia. If you know these 6 or 7 questions, you will get all the questions right on step 2 and you will have a fine life. When you have one PVC, it's irrelevant. When you have 2 together, it's called a couplet. When you have 3 premature ventricular contractions together, it's called a triplet. When you have 4, it's not quadruplets. It's ventricular tachycardia. Now, ventricular tachycardia means a wide, complex tachycardia, as opposed to supraventricular tachycardia, which is narrow. The QRS complexes are wide, and by definition, it has to be going at least above 100, usually above 120, or in fact, even closer to 160 a minute. All wide, complex tachycardias are generally considered ventricular tachycardia. The etiology of ventricular tachycardia is ischemia, cardiomyopathies, and electrolyte abnormalities that can affect conduction systems, which is basically high or low potassium, calcium, magnesium problems. You see, sodium and chloride don't do anything, and that's because there's no ungated channels for sodium or chloride. It has to do with calcium channels and potassium channels. Magnesium makes it abnormal because it makes it easier for all neural tissue to depolarize with low magnesium. Hypoxia, the same thing. Psychiatric medications like the thyroidazine drugs also have some cardiac conduction abnormalities. The key issue in VTAC and all arrhythmias is what's the level of hemodynamic stability? If they're unstable, such as chest pain or shortness of breath, hypotension, confusion, you must shock synchronized cardioversion. Now, jugular venous distension by itself is not a sign of congestive failure. Shortness of breath is. There's intermittent canon A waves because that's atrial systole against a stiff, non-compliant ventricle. Atrial systole against a stiff, non-compliant ventricle. But ventricular tachycardia, if it has chest pain, shortness of breath, hypotension, confusion, you need to shock me now. If it is stable, you use amiodarone first. And that's not random, that in your algorithm here it says amiodarone first. It is amiodarone first. Amiodarone is superior to lidocaine. Lidocaine is only if the amiodarone doesn't work. Procainamide is only if the lidocaine doesn't work. And you try amiodarone, lidocaine, procainamide. Unstable chest pain, shortness of breath, hypotension, confusion. You can't use soft things like being pale or sweaty or decreased capillary refill because it's too nonspecific. You got to use hardcore things like if you're hypotensive, you're going to die. If you got chest pain, you're going to die. If you're confused, you're going to have a stroke. Any one of those things means cardioversion. Torsades de Pointes is ventricular tachycardia with an undulating baseline. Goes up and down and up and down. Makes it look like it's twisting around a point. It's VTAC with an undulating baseline of a QRS. It can be initiated by a premature beat or an abnormal ventricular repolarization or a long QT. Yes, long QT can progress into torsade. It's VTAC. VTAC can be caused by a lot of antiarrhythmics, quinidine, procainamide, disopyramide. See, now you know why medications to convert people are not routinely used, because the antiarrhythmics can themselves cause arrhythmias. Psychiatric medications can cause arrhythmias, but the biggest thing is this. That was the failure of antiarrhythmic therapy. People said, well, we don't like PVCs, give them antiarrhythmics. Yeah, but antiarrhythmics cause arrhythmias, man. It's kind of like buying something for someone. Say, listen, I'm buying you a car so you can be safe on the road. And it's like, no, driving causes accidents, dude. Potassium, magnesium, calcium causes abnormalities. Why do CNS lesions do it? Why do we get cerebral T waves? Well, we're not sure, but we think it's because there's an intense vasoconstriction from sympathetic outflow causing a vasoconstriction of your heart, provoking ischemia. Torsade can present with dizziness or syncope or hypotension or just palpitations. The treatment is certainly if there's an electrolyte abnormality to fix the low calcium, the low magnesium, the low potassium, and then some people get better with overdrive pacing, but if they're unstable, you must cardiovert. Unstable, cardiovert, the same things that make it unstable for VTAC. Chest pain, shortness of breath, hypertension, confusion, shucky. Our next section is ventricular fibrillation. A 54-year-old man, he's at the opera. He jumps up and grabs his chest. He falls into the lap of the woman who's next. And he's breathing. No, he's dead. A 54-year-old man, he's at the opera, and he falls into the lap of the woman next to him. He's not breathing. He's dead. He confirmed. First, you got to make sure he's unresponsive, not just sleeping. Gets chest compression, ventilation, chest compression. Do those chest compression. Yeah, that's right. ABCs becoming CABs. Wow. Compressions, most important thing. The EKG shows VFib. What do you want to do? He's not breathing. Ventricular fibrillation has no organized electrical activity. It is caused by ischemia, infarction, cardiomyopathies, but ischemia, most likely. And there's no organized activity. That's why when you shock them, it is an unsynchronized cardioversion because there's nothing to synchronize to. Ventricular fibrillation means automatic CPR and shock me. Clinical presentation. You could call it unresponsive. Other people call it dead. And VFib on an EKG, that's correct. Because when you have a person who's pulseless, you can't tell a person who's pulseless from VFib, from a person who's pulseless with asystole, from a person who's pulseless with VTAC. They all tend to be dead. But you've got to confirm with an EKG. Make sure that EKG is on. Make sure that your leads are not just loose or disconnected. Make sure that it's accurate first because you want to be sure that you're not having a person who's simply got a artifact because chest compressions on people who are not really dead and in VFib will kill them. If you do chest compressions on someone who's not really in VFib and their heart's beating, well, they're going to have VFib, even if they didn't once you started the compressions. Make sure it's real. There's a beautiful picture of VFib. No matter what it says in the case, blah, 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 shock it. Unsynchronized cardioversion. No respirations, shock it. Don't intubate. Because then all you have is an intubated dead person. Shock it. Shock it. Shock it. Shock, epinephrine, shock, amiodarone, shock. That's it. Shock, epinephrine, shock, amiodarone, shock. That's done. Beryllium is dead. Vasopressin is an alternative to epinephrine. What's the point of the epinephrine and the vasopressin? Because if you shock them a couple times and it hasn't worked, it's unlikely that a fourth shock's going to work. So what you do is you give vasopressin or epinephrine to try and shunt blood into the central circulation. Let's increase that perfusion of the heart, and maybe the next shock will work. And that's what the vasopressin and the epinephrine are for. Oh, I shocked him again. It still didn't work. Amiodarone. Why? Because a fifth or sixth or seventh shock is unlikely going to work. Let's give amiodarone to make sure that the next shock might work. What do you do then? Lidocaine? Yes. But amiodarone or lidocaine, if they ask you between them, it's amiodarone. Ladies and gentlemen, for this section, the most important thing for you to understand is what makes an arrhythmia unstable. That's why we've been so repetitious on that. That's on purpose. I want it programmed into you. The most important thing on AFib management is that you know who should be anticoagulated, and that dabigatran or rivaroxaban are not too new to be on your exam. Those drugs are out for years. Don't use them in valvular AFib, and remember, you don't need INR monitoring. Step 2 is not going to ask you things that are speculative. They're not going to ask you to choose between dabigatran and rivaroxaban. No one can answer that question.
They're going to ask you a question like this. Which of these needs INR monitoring? Which one doesn't? A person has a CHADS of 3 and 4 in a previous stroke. That's clear. That's clear. They're not going to split hairs. And remember that everything that you're doing is deeply good. You're not wasting your time on any of this. The question we always have in our life is our lives worth it? Is our efforts worth it? Well, I'm telling you, none of your efforts are lost. Now, I can't spare you the suffering you have to go through for all of your studying. All I can tell you is that we will suffer with you, if nothing else. See you in the next section.